So hello, everyone. My name is Alice.
And I'm Misha Desai.
We're students at HBS building a startup called Anise Health, which is a digital mental health platform for AAPI communities. We're humbled by such a great turnout. We recognize that the AAPI community is going through a very tough time with the recent spike in anti-Asian violence, and we hope that this panel will serve as a space for us to discuss this issue. We're so fortunate to have three distinguished researchers and clinicians join us today, who will not only share their research and perspectives, but also address the topic of anti-Asian racism.
First up, we have Dr. Hall, who is a professor emeritus of psychology at the University of Oregon. Dr. Hall's research focus has been on culture and mental health, with a particular interest in Asian Americans. Using neuroimaging and questionnaires, he is currently investigating if the personal relevance of psychotherapy influences treatment effectiveness. He is past president of the Asian American Psychological Association and author of the textbook Multicultural Psychology.
Then we have Dr. Janie Hong. Dr. Hong is a psychologist and clinical associate professor at Stanford University of Medicine. She's a founding partner at the Redwood Center for CDT and Research, where she maintains a small private practice. Her research and clinical practice is focused on developing evidence-based ways to individualize care and address diversity factors in therapy without inflating stereotypes. She's also the current chair of the Asian American in Behavior Therapy and Research Special Interest Group in the Association for Behavior and Cognitive Therapies.
And last but not least, we have Dr. Uma Chandrika Millner. Dr. Millner is a counseling psychologist and assistant professor at Lesley University. Her research focus is on recovery and rehabilitation from a holistic, empowering, and social justice lens. Her research is participatory, where individuals with lived experience are collaborative partners. Her work looks beyond therapeutic interventions and at the support that families and communities can provide in order to help individuals live successful lives. She also has extensive experience working with Asian individuals, families, and communities.
So for today's panel, each of our experts have prepared a short presentation for us. After a short presentation from each of the panelists, we will take a short 5-minute break. After the break, we'll kick off the panel discussion in which our panelists will answer questions from the audience. As you already know, the Q&A box will remain open throughout the webinar, so please feel free to type in questions as they arise during our panelist presentations, as well as during the panel discussion. So without further ado, Dr. Hall, please take it away.
Thank you for inviting me here on this important topic. I want to start right away addressing the current mental health needs of AAPI communities. This is a National Day of Stop AAPI Hate, and it's important for us to pay attention to our own mental health needs. One issue that's very important is physical safety, being safe, feeling that one can be in public, go shopping, get vaccinated. Just physical safety is really particularly important at this time, particularly for AAPI women. And I just heard about this program in San Francisco called Walking Buddies, where younger people in the community have volunteered to accompany Asian Americans as they're walking or going on errands, and getting social support and being with friends and feeling physically safe is important. Second, psychological safety is also important. So these racist events are not your fault. It's not something you've done. It's not something about you. It's a systemic problem. And Daryl Wing Su from Columbia University has developed a microintervention toolkit, and this is available to the public. And it discusses ways to make the invisible visible, as he says it, to bring to light what microaggressions are, and when one feels safe, to be able to intervene both at an individual level and on a systems level to try to undo this systemic racism. So I wanted to start with acknowledging the time that we're in and the stress and anxiety that we all feel in Asian American communities. Another resource is the Disorient Asian American Film Festival of Oregon. I'm on the board of directors. This film festival is going on right now. One can get tickets at disorientfilm.org. And this festival shows a diversity of Asian American experiences and has a social justice theme, but there are also lighter themes such as music, romance, and the value of the Disorient Asian American Film Festival of Oregon is that it educates people about history and current issues in the Asian American community. So the tickets can be purchased at disorientfilm.org. So Asian Americans are the least likely group to use mental health services. This was a meta-analysis, a summary of studies from the 1970s to 2008. And only about 12% of Asian Americans ever use mental health services during their lifetime. Stanley Hsu and Nolan Zane wrote a classic American Psychologist paper in 1987, and I saw Stanley Hsu on this webinar, so welcome, Stan. Hsu and Zane discuss credibility, whether the treatment and therapist is perceived by the client as beneficial, and giving, is the treatment perceived as a client as immediately practical. In many Asian cultures, there's traditions of gift giving, and the therapist can provide immediate, practical, symbolic gift to the client. This might involve symptom relief or reassurance. And because many treatments are not credible and do not involve some practical benefit, this may be why Asian Americans underutilize mental health services. Culturally adapted treatments were developed in response to this underutilization, and there are therapist adaptations such as therapist-client ethnic matching. Therapist cultural competence has been emphasized. Therapy adaptations involve tailoring therapy content, and these cultural adaptations work. This was a meta-analysis I did in 2016, and we found that culturally adapted treatments outperformed other conditions. No treatment, other manualized interventions, the same unadapted intervention, and other active interventions. So culturally adapted interventions work. But culturally adapted treatments have not reduced mental health disparities. This in part is because of the limited availability of culturally adapted treatments. And also culturally adapted treatments are applied to address features associated with a particular group. And not every member of the group may have those features. So if there's an intervention developed for Chinese Americans, not all Chinese Americans are equally acculturated or aware of their own culture, and some who are more acculturated may see cultural adaptations as less relevant to them. The personal relevance of psychotherapy model was developed by me and many of my colleagues, including Janie Hong, who is the second presenter today. And we argued that most traditional approaches have focused on the universal aspects of therapy. So evidence-based treatments are based on the assumption that these interventions are universally applicable. Culturally adapted treatments focus on the group and the cultural context, but they fail to integrate the individual context often. And so the failure to integrate the universal of the group and individual, which involves one's personal context, individual differences, this failure to integrate these different levels has resulted in the relative ineffectiveness of culturally adapted treatments when widely applied. So the idea here is what we call precision medicine to determine what aspects of the universal and group apply to a particular individual in a treatment setting. Nolan Zane, who's pictured here, contends that face concerns among Asian Americans may prevent treatment utilization. And his work is on face, which is the social reputation, one's social reputation based on traits, attitudes, and values that one presents to others. And face is saved by fulfilling roles as a member of a group. So as a family member, you might be a parent, a child, a sibling. At school, you might be a teacher, a student. At work, you might be an employee or a supervisor. So fulfilling your roles in different social settings helps one save face. On the other hand, mental illness can produce face loss. A concern about loss of face is negatively associated with self-disclosure in therapy. So if you're concerned that your mental illness is going to reflect negatively on yourself and on your family and even your community, you may be very reluctant to speak about it and certainly reluctant to seek help. But approaching these personal issues as solving specific external problems saves face and provides a practical gift. So if a treatment focuses on family, school, and work and solving problems in these situations, this may result in less face loss than focusing on mental illness as a personal disease. I want to wrap up here by talking about some work my colleagues and I have conducted on the personal relevance of psychotherapy, and we've implemented social neuroscience techniques involving fMRI scanning. And neural action in the brain increases in self-processing networks implicated in processing of persuasive messages. So one of these areas is a ventromedial prefrontal cortex. And so if you're on social media and you get an ad that is relevant to you, this area of your brain is going to light up. If you get an ad that is irrelevant, this area of your brain is not going to light up. CBT, cognitive behavioral therapy, the traditional and mainstream treatment that is evidence-based, has much face loss potential because there is a focus on the self. Problem-solving therapy, on the other hand, has a potential to save face. The focus in problem-solving therapy is on goal setting and external problem-solving, and problem-solving therapy may be personally relevant to many Asian Americans, especially those who are unacculturated and looking for a pragmatic and practical approach. So in our study, we wanted to determine the personal relevance of problem-solving therapy versus cognitive behavior therapy. Again, external problem solving allows the client to save face with a focus on family, school, and work issues. There's less focus on the self, and external problem solving provides a symbolic gift because it offers the client something immediately practical. So in our study, we had 28 Asian Americans from Eugene, Oregon. These are the breakdown in terms of generation. And we presented randomly ordered excerpts from cognitive behavior therapy or problem-solving therapy treatment manuals in an fMRI scanner. So these participants were in the fMRI scanner and they saw excerpts of the CBT or PST treatment manuals, and we measured brain response to these different types of treatments. So these are some of the excerpts that we use. This is from CBT. When we look at your thoughts, sometimes they're true, not true, or have a grain of truth. We will teach you how to evaluate the accuracy of your thoughts by looking at the evidence. What evidence is there that the thought is true? What evidence is there that the thought is not true? Another CBT excerpt, there are many common mistakes, cognitive distortions people make in their thinking. By figuring out what cognitive distortions you may be having, you can respond to situations in a more healthy way. One cognitive distortion is called all or nothing thinking, where you see things in very black and white terms. For example, if you were feeling depressed and unable to finish your homework, you might think that you were a failure or a failure forever. A problem-solving therapy excerpt, one skill that may help you is called problem definition or clarifying the nature of a problem. You will learn how to set a realistic problem-solving goal and identify the obstacles that you are currently preventing you from reaching that goal. For example, if you want to raise your GPA, we'll figure out a realistic GPA that you can achieve and identify the very real obstacles that are currently preventing you from reaching that. Another PST excerpt, one skill that may help you is called problem definition or clarifying the nature of a problem. You will learn how to set a realistic problem-solving goal and identify the obstacles that are currently preventing you from reaching that goal. For example, if you want to raise your GPA, I'm sorry, I just read that. Okay, generation of alternatives, in which we teach you to use your creative skills to brainstorm different types of solutions. You can come up with many solutions as you can. So basically, this is a brainstorming type of problem solving. So these are the results. This is a summary of hundreds of brain scans. And what we see here is activation in this ventromedial prefrontal cortex area. And the activation in this area in response to problem-solving therapy excerpts versus cognitive behavior therapy excerpts was greater. So across all these 30 participants, there was greater medial prefrontal cortex response to problem-solving therapy than to cognitive behavior therapy. And again, this medial prefrontal cortex area is associated with personal relevance. These effects were more pronounced in first and second generation Asian Americans. Those born in Asia or those whose parents are born in Asia showed more of a contrast here. So for these less acculturated people, problem-solving therapy was more relevant, particularly more relevant than cognitive behavioral therapy. And these effects are less pronounced for third generation Asian Americans. So another study we did to follow up, we didn't have a comparison group. So we did use a comparison group in this study with white and Asian American college students. And we wanted to ask directly what the personal relevance, liking, and helpfulness of problem solving versus cognitive behavior therapy vignettes were. And so for European Americans, these differences are actually not statistically significant. Relevance, liking, and helpfulness of problem solving and cognitive behavior therapy were essentially the same. But for Asian Americans, these differences were pronounced and significantly different, with problem solving therapy being seen as more personally relevant than cognitive behavioral therapy. So some concluding thoughts: dynamic sizing, which was proposed by Stanley Su, suggests considers how universal healing principles and group contextual issues can influence individuals, and combining these universal group and individual levels can be implemented to assess the personal relevance and effectiveness of interventions. And considering all three levels of influence does not always necessitate cultural adaptations, but can involve matching an individual's needs, such as face concerns, with an existing approach, problem-solving therapy, which helps a person restore face. In terms of public health campaigns to increase mental health service utilization, public health campaigns could reach a broader audience by emphasizing the personally relevant aspects of mental health services. And my colleagues and I, including Art and Chris Nezu, who developed problem-solving therapy, and Stanley Su is a consultant on this project, as is Nolan Zane, we're trying to develop a problem-solving therapy app to address stress among Asians. So bringing the therapy to the clients rather than having the clients come to us. So thank you. I'm finished and look forward to the discussion and to the next two presentations.
Thank you, Dr. Hall. Next, we have Dr. Hong.
Hello, everyone. My name is Dr. Janie Hong, and I decided to redo this presentation that I gave actually yesterday at the Let's Talk conference. Given the time constraints, I didn't get a chance to fully flesh out some of my ideas, so I wanted to make this available to those of you who maybe weren't available to come to the talk, but if you did attend, to be able to flesh out some of those ideas more for you. So I hope this is helpful. So just to give some context, I went into this field because I remember very clearly as an undergraduate thinking that the models and treatments that have been developed, mostly in terms of psychotherapies, are very much based on Western models of good mental health, how to achieve mental health, what the signs and symptoms of good mental health are, and really felt that oftentimes that these ideas were counter to other cultural contexts, particularly Asian cultural contexts, and wanted to study this as well as be an advocate for including diversity factors into our treatments. And it's been a long journey. I've been doing this for over 20 years and have some ideas and thoughts that I want to share with you today. And I'm really grateful that there's such a growing interest in this, and with the recent growth in anti-Asian sentiments and discrimination and violence that's come to the forefront in terms of media, not necessarily that it's just happening now, but that it's become more of something that people are thinking about and talking about. It's even more important that you're here, that you're showing interest, and I'm hoping it's something that will continue rather than it being just a spotlight in a moment in history that then goes invisible again. So one of the things before even thinking about how to incorporate culture or think about culture in the context of psychotherapy, I want to go through on a more higher level, like what are some of the problems if you don't focus on culture, and what are the problems that do come up if you do focus on culture in therapy? When thinking about not focusing on culture in therapy, there's several problems that can come up. One, it can reinforce the belief that there's something wrong or broken with the individual that needs to be fixed, or something wrong or broken in the context of where that individual is sort of managing. So if you have a patient who identifies, for example, as Asian American and has parents who were raised and are immigrants and are raised in an Asian context, oftentimes there'll be conflicts in values and beliefs about how to approach different situations, including parenting practices that may be different from Western cultural kind of ideals. And I've often heard from some of my Asian American clients of how they've received pressure from their past therapists that the ways that their Asian parents are still doing laundry for them or coming over and making food for them and bringing food and doing all these different things that they feel is not helpful for them being independent and for them to set clear boundaries with their parents so they don't interfere with their independent goals. I'm not saying that's necessarily a bad thing, but it doesn't actually take into consideration what the goals are for the patient, and in a way sets up a situation where it's saying the cultural ideals and beliefs that may be driving their parents' behavior are wrong, and reinforces their idea that maybe there's something pathological or problematic that the client hasn't been able to recognize, and so that's one issue. Another issue is that it can really undermine alternate pathways to good mental health. So here's using that same example, if the client really wants to maintain a relationship with their parents and is feeling conflicted because they're receiving messages that the way that their parents are treating them is abusive or not respectful of their boundaries, it may prompt them to feel like they have to cut off ties or create boundaries in ways that that doesn't really fit with their goals. And without consideration of the kind of cultural values and context, it creates a barrier to other ways that they could potentially have a relationship with their parent while still changing it in ways that would help them feel more positive about that relationship. And then the third one is a really important one. If we don't talk about culture in therapy or in therapeutic context, it creates more of that invisibility and that sense of what some of my patients call gaslighting of the experience that they have on a day-to-day basis, or they have in certain contexts, as not being valid or real, or a matter or an issue, even or more problematic, that it's a problem with the client, that somehow the client was misinterpreting or misunderstanding of the experiences that they had, particularly if it was one that is consistent with kind of systemic norms, and makes the client feel, again, that they're the ones who have the problem and need to be changing and thinking differently about it. On the flip side, there are some difficulties that come with trying to focus on culture in therapy. One is that often, the therapist, especially if the therapist is not familiar with the particular cultural context that the patient is coming from, it places a pressure on the patient to educate the therapist. So I'm sure for those of you who are more well-versed in some of the social justice and trying to learn more about how to work with clients of a different cultural context, this is something that shouldn't be placed on the patient and can create undue tension and problems where the patient is coming to the therapist for guidance and help, and suddenly the patient is being put into a role where they're helping the therapist in a way that shouldn't be their responsibility. The second piece that can be hard is that if a therapist is feeling unclear of how much of the problems that a person is feeling is due to cultural differences, or maybe influenced by culture, or that their goals might be different because of their cultural context, I've seen therapists then become very unclear of what goals to even be promoting and to be pushing for. What is pathological? What is anxiety? When do I use these strategies? When do I not? And that too can lead to a situation with the patient where the therapist is leaning on the patient to create almost like the treatment plan in a way that patients shouldn't be expected to do and are ill-equipped to do, and why they came to therapy in the first place. And then the third issue is a really important one. I am a huge proponent I've dedicated my life to the importance of including diversity and individual factors, cultural factors into therapy. But what I've often seen, and there's been some research to show this, is that when therapists or other professionals work to build their cultural responsiveness skills or sensitivity skills, we also see an increase in stereotyping and a tendency to, in the effort to not try to force the patient to educate the therapist, they will then try to take this leadership role, but then make certain assumptions about the patient that may not be relevant to that particular patient, or that patient may not be in a space where they would agree with that, even if it may be something that does, or they want to share with that particular therapist. And so there's a lot of assumptions and potential ways to rupture the therapeutic relationship if the therapist makes these assumptions based on sort of cultural trainings that they've had, and can be problematic in the therapeutic relationship. So given this, what do you do? I mean, obviously, as the whole reason why we have this talk and this the series of conferences is we want to raise the importance of culture and the need to be meeting the specific sort of cultural needs of Asian Americans and other cultural groups. But what do you target? And how do you promote this change? These are the two main questions as a therapist in general that you're trying to figure out for each of your clients. How do you do this if you want to also incorporate cultural factors? When thinking about what you target, to me, that's the formulation or the sort of understanding of what are the problems that the patient is coming in with and wanting to change to lead to a life that is better, feels better, and more oriented and grounded. I want to first start out, I'd always find it really helpful to use a case example. And I will be sharing one that I've actually written about in another article that you can find in the resources section, but wanted to use that to sort of highlight the principles. I always feel like it's better to have a concrete example when hearing about different ideas and principles. This, of course, all identified information has been changed, and in order to protect the confidentiality and privacy of this client. So this is, I said the case of Mr. Be in Control, but let's call him Joe. Joe walks into my office looking around the room. He's clearly uncomfortable and keeps clearing his throat. This is the first time he's seeing a therapist, and Joe's clearly quite nervous. Joe's 47 years old, Chinese American, and lives in the Bay Area with his wife and 2 young children. Joe grew up in the area, and his parents and younger brother and brother's family live within 5 miles of him. Joe's parents own several businesses, including 2 local restaurants. Although both Joe and his brother help their parents with the restaurants and other businesses, Joe also works as a freelance computer programmer and is working on 3 different projects for 3 different companies. I asked Joe why he's seeking therapy now for the first time. Joe looks down and struggles to make eye contact. Well, I had a bunch of unexpected health problems last year. I mean, I'm fine now, but I haven't really bounced back since then. I feel a little out of control. How so? I ask. He's quiet and looks embarrassed, and you can see tears welling up in his eyes. I'm super irritable. I even yelled at my wife a few times. Well, not yelled, but I did raise my voice, and I've been snapping at my kids over the stupidest things. So stupid. What kind of father am I? I'm having a hard time with my parents. I've always had a difficult relationship with them, and it's just getting worse. I don't know if it's me losing patience or if they're just getting more annoying. I feel like they have no respect for me at all and all that I do, and they're always comparing me with my younger brother. They can't stop telling me how I'm messing up all the time. I'm disappointing everyone. And I'm getting so annoyed with how everyone just doesn't care and keeps asking me. I'm really thinking about not coaching my son's soccer team next season. I don't think I'm in the right mindset. I just need to get a control over myself, and I just don't enjoy anything anymore. Yeah, I work a lot. I mean, it's supposed to be part-time, but I don't want to put anything with my name on it that isn't really good. So I spend a lot of time making sure everything is just right. I guess my parents have always been really good at pointing out what I'm doing wrong. So I guess I'm just really good at noticing when things aren't right. Maybe I'm just tired. I don't know what's happening. I just feel like I'm letting everyone down, and I just can't pull myself together. I don't ever remember having this kind of problem. It doesn't help that no one ever seems to notice that I'm having a hard time. But that's my fault, right? I just need to step it up and just get it together. Things would just be so much better if I just felt better and could just get a control over my temper. If you just really handle everything, and then I would be totally, totally fine. Now I could say a lot about Mr. B in control or Joe, and that would be another, I guess, presentation where I walk through how I worked with Joe and what are the things that I did with him. But I wanted to use this case example to sort of highlight the principles of how I think about incorporating culture into therapy, and bringing in the case example to highlight that. Again, another presentation to actually talk about the specific strategies that I used. So in therapy, the idea of what do you target? One of the principles that I think about is often in therapy models, as well as within the medical model setting, we think about problems in terms of deficits or symptoms. What is the diagnosis? What are the problems or things that are wrong that need to be fixed? But in the context of culture, it creates that sort of idea that a particular template or way of being is right, and it doesn't allow for cultural differences. So the way I approach that is to think about the problems that a person is experiencing as differences, not deficits, and really taking a non-judgmental stance to understand what is different, what is happening that is creating discomfort for you. And so in the context of Joe, he would agree with, and this is really important because you could see that he is saying that his parents are annoying and problematic, rather than taking those words and saying your parents are wrong and problematic. We would talk about more just like, what are the things that are difficult for you? And so, we would list off things like you're having a difficult time with your parents. So that's something that is problematic. You're feeling like you're acting in ways that are inconsistent with your values and the way you want to be acting. And you're feeling sad and frustrated with the way that you've been acting. These are the things that are different and what you're thinking is what it's causing the problems that you've been experiencing. The second piece, which I'm sort of alluded to in the first, is rather than focusing on specific behaviors are not meeting expectations. And oftentimes those expectations are norms that are set up by our society or even in our treatment manuals or models. Focusing on just the behaviors themselves and trying to understand why those behaviors are happening, what sort of goal or function is it trying to meet, and probably not meeting it well, which is the reason why you're feeling the discomfort and problems that you're experiencing. So for example, in the context of Joe, he is repeatedly checking his work. I could say to him, if I were focusing on the behavior itself and why it was wrong, I could say, well, don't you see how that takes up so much time? Wouldn't it be better if you didn't check your work so often? Let's lower our standards, or let's do these different things that will make your life so much better. There's nothing necessarily wrong with that, but the problem is we're not really taking time to understand, well, why is he doing that? What is the function of that? And in this context, most likely it's because he's feeling he has some sort of inflated sense of what the consequences will be. And he's really trying to prevent certain consequences from happening. And in his mind, repeatedly checking is the best way to meet that goal. And part of what I would want to do is to say, okay, if perhaps there's another way that you can actually meet the goal of feeling confident in your work, feeling confident that you are producing good work. Is it possible that this strategy is not getting you towards your goal? Similarly, when focusing on parents, this is even more important, where he's saying they're being disrespectful, annoying, constantly pointing out all the things that are wrong. You want to validate the pain that that causes him, but rather than focusing on that the parents are doing something wrong and shouldn't be doing that, trying to understand what is it your parents are trying to do? How can we understand the function of those behaviors? Sometimes I'll bring in the cultural context, where in Asia, there's a lot more focus on identifying the things that might be hindering kind of like common group goals and being able to meet group needs. And so there is sort of this self-critical or critical sort of orientation of trying to pick out problems, but the idea being this is how we can make sure that we're all sort of working well together. When you bring in that context, you can get more of an understanding of what your parents are trying to do. They're not trying to hurt your feelings or shame you per se, but that's their way of trying to meet their goal. And it functions like this for them. And getting the patient, in this context, Joe, to sort of think differently about those behaviors, and then thinking, do we want to work on translating what they're trying to do, and so that it doesn't hurt you as much? Or like the one with the checking behavior, is there something where we can try to do to try to shift the behavior to better meet those goals? This third one is actually really important, particularly in the context of AAPI mental health, because a lot of the discrimination and problems that Asian Americans will often talk about in terms of discrimination and racism, frankly, can feel invisible, or a way where they're not quite clear, is this me or is it that other person? Should I be thinking differently, especially when their views may counter what is actually being promoted in sort of a larger kind of white context, can lead to apologies. Oh, I'm so sorry. It's like, I didn't really realize that it was supposed to be this way, and a continual sort of hiding of or retreating of needs and wants that are valid. And so working with your clients to say, okay, let's try to understand what is it that you're feeling, what's causing you to feel these different feelings, what are your goals in this situation, what's different, so kind of bringing in the other two principles, and then figuring out how do we advocate for that rather than apologizing for having a different view. They may actually bring in something more rich and wonderful if we can sort of elaborate on this difference and bring it to the context. And again, this is a place where how we promote diversity, right? Diversity can and does improve. I think in most contexts, if we have lots of different ideas, it can only improve the situation by having more options. And so similarly, having clients to sort of think in this way. So how do you promote change? One of the things that I think about, and the term that I've come up with, is this idea of collaborative curiosity. Patients come to you because they want to develop a relationship where they can trust your guidance and work with you to make improvements in their life. To be able to build that sort of collaboration and relationship, and to actually work on change, requires, in my mind, a few key pieces. And this, I think, transcends just psychotherapy. If you want to have a good collaborative relationship in solving identified problems, which is the first part of what we've identified to target, there are core pieces that we need. The four that I've identified here, I'm sure there are others, is how I like to think about it. One, we need to have a really clear understanding of what we're even working on, a shared understanding of the problem. This is what I think of in terms of a formulation. This may reflect a little bit of my own sort of cognitive behavioral EBT background, but to me, this is so important, where with all of my patients, I want them to really understand what we're doing, why we're doing it, and what it is that we're trying to target. It should never be a mystery. The second is, how do we move to solve these problems and not get caught in the swirl of who's to blame? This is a very tricky piece, especially if someone's coming to you where they have been deeply hurt by other people, whether it be family members or people in their social context, or maybe even just part of the system. And, you know, it goes back to this idea of function of the behavior. So if they are continuing to swirl in the sense of blame and how could they, and it was their fault, really trying to understand, well, what are they trying to meet, or goal are they trying to meet? And in my mind, it's most likely this desire to feel validated that what they experienced was wrong. And it's not their fault, or they're not overreacting, and they're not misreading the situation. And sometimes blaming or putting blame creates that clarity so that the other person doesn't have to feel shame about it or start doubting whether they might be wrong about how they're feeling, or that the current situation is a problem or not a problem. So one of the things that I do is work on figuring out, is there a better way to feel that the situation is valid, but also work to not have it create so much pain and not be such a problem or something that interferes so much in their life. Because while the blame is validating, it's not actually doing much to relieve the pain. And so we'll set up different strategies to work on that. The third piece is being flexible and responsive to changes. So I always work with my patients. We have an idea of what the problems are. We then work to develop some hypotheses about what might help with a particular problem. But I take on a very exploratory, open stance of like, we could be wrong. We have some ideas. Let's try it out. And if the data come back and show us that it's not actually helpful, or it's not what we were thinking, great. Now we can better go back into the shared formulation in the plan, or understanding of the problem. We can go back and say, okay, then what is, based on this data, how can we calibrate and improve on how we're understanding the problem? And this works really well if you are a therapist who doesn't understand the cultural context well. Rather than leaning on the patient to educate you, you can develop hypotheses. And again, rather than leaning on the patient or making assumptions and stereotyping, you can come up with hypotheses, but be really open to being wrong and working closely with your client to figure out, how can you test this out to actually see if these ideas hold water. Maybe they don't. Maybe it's just a stereotype, or maybe it does. And what does that mean? And how can we learn from that? And what kind of interventions can we use to sort of help us as we're developing this formulation? And the final piece, which is sort of part of this, you never want to put yourself in a stance where it's with any collaborative partner where you're facing each other and saying, I think this, and the other person's thinking, I don't think this, in terms of when you're looking at, is this intervention helpful, or is this an actual problem? It doesn't help anyone, because it then creates discord, right? The goal is to actually strengthen your relationship, but if you're continuing to argue over whether or not something is right, and stating your point, you're not going to go anywhere. And so how do you build and create this sort of shared process and formulation? And I wanted to spend extra time on that. To me, one way of doing that, and I wanted to highlight it because I think I have such strong feelings about it, are symptom measures. They really create some sort of a metric and a rubric of identifying problems, identifying whether change is happening in the problem that is separate from my opinion or the patient's opinion. It is something that we can look at together and be very thoughtful about and review the data. And we can discuss how much we agree with what the measure is saying, but at least it's not based on another person's opinion that we're having to have this discussion about. And it also allows, as I've written here, a way to develop hypotheses. Let's say we disagree with what the measure is saying. At least it's a starting point. And then to say, if we disagree with this, then how can we test out what we actually think might be an alternate way to look at the situation? This one measure is telling us that it's a problem. Maybe it's not. How do we test that out? And creating experiments and testing out these hypotheses and then reviewing the data together, and having very clear ways of reviewing the data, or how you'll be collecting the data, just really helps with this process. As an example of a measure that you could use, this is the Frost Multidimensional Perfectionism Scale. And I often give this to my clients, and this is partly informed in the research of knowing that perfectionism tends to feature more highly in AAPI populations. It fits with sort of East Asian values and ideals. And I can't tell you the number of times that I've had clients who've assumed that this measure was actually a measure of Asian values or beliefs, when in fact it was created to identify something quote unquote pathological or problematic that needs to be changed. One piece of that's different on this measure than say some other symptom measures, that it actually includes questions about parental expectations and criticism. And so here, imagining this is Mr. being in control, or Joe, the score red representing high elevations, blue being mild and yellow being moderate, and then having the norms next to this, it gives us a way to have a conversation saying, this is what the measure was intending to assess. It's saying that your standards and the ways that you're approaching the standards or your behavior in your life is harmful, and that this is what's interfering. And it's not because you're not having good control, but perhaps it's the actual standards and perfectionism that is leading to these problems, and it leads to a conversation. I can't imagine having that conversation with a patient and saying it's because you're being too perfectionistic when they're so staunch on the fact that it's because they need to actually be more perfect, without having a measure to sort of have a discussion about this. It completely releases that pressure of me sort of trying to shift their formulation of what the actual problem is. Similarly, in the context of Joe, this one of the measures that we give him is the OBQ 44, or another one where he has this inflated sense of responsibility, and we see the perfectionism again lighting up, and this inflated sense of responsibility to prevent bad things from happening that's highly elevated compared to the norms, which again are on the right. And with that, it creates a hypothesis as to what's driving his sadness and frustration, and that the strategies he's using to maybe achieve that is really at the root of what's causing the problem. And it gives us a way to measure change. So as we're doing therapy if he agrees that these are things that he wants to be working on and changing, we can then have something to systematically see if there is improvement on these measures. So I'm going to conclude there. I would love to give another talk to walk through the different interventions that I use to help make this changes for Joe, and can say that actually I think I have the question, the data for that. Here we can see that in distress measures over time, Joe improved greatly and was able to sustain his reduction in depression, anxiety, and stress scores. But more importantly, we find that through the therapy, we were able to reduce what we felt were the core sort of drivers to his problems, perfectionism and an inflated sense of responsibility. And it fit with what we also saw in behaviorally and in his life, marked improvement in his relationship with his parents, reduced numbers of hours of working every week, increased engagement in his hobbies and time with his spouse, and just an increase in flexibility and how he approached different situations. And a lot of those strategies ended up not being those of typical kind of treatment models. And so at some point, I would love to talk about that in another context, but really highlighting how you can incorporate culture in a way that is systematic, evidence-based, and thoughtful, without kind of running into the potential barriers or problems that I talked about earlier. Thank you so much. I am glad to be able to give this talk again. And if you have any further questions, you're welcome to reach out to me via email. Thanks again.
Okay, well, hello everyone. It's so nice to have such great representation here. It's good to see you all virtually, of course. So I think my presentation is going to be a little bit different from what you've heard so far. It's a little bit more of a taking a step back. Some of this material may in some way trigger past histories of, experiences of oppression or trauma, just to give you a heads up if you needed to step away. But I really wanted to start with a land acknowledgement that we will be talking or have been talking about immigration experiences, and perhaps will in this virtual gathering. In this context, we recognize and honor our siblings who were and are stewards of this land that constitutes the ground beneath our feet. So historically, the home of indigenous peoples, many of whom have been forced to leave for other lands. The ground beneath my feet is in Newton, Massachusetts, which is the land of the Confederation of Indigenous Massachusetts. So we remember that Indigenous people are not a people of the past, but are here with us now. So if there are any Indigenous people on this virtual space, you're invited to share your tribe in the chat box so that we can recognize you. So thank you for doing that. So I'm going to keep moving in the interest of time, and perhaps Shob, you can let me know if someone posts in the chat box. So the other thing I wanted to do real quick is sort of do an expression of gratitude for this work. So first and foremost, I want to acknowledge and express my gratitude to all the Asian American individuals with lived experience. And we use the term lived experience or individuals in recovery as a way to kind of substitute the term mental illness, which can have very significant kind of biological implications for etiology. So I want to thank family members and Asian mental health providers for their kindness and generosity with my research. It is my intention to honor you and elevate your voices today. I also wanted to thank Asian peer leaders. So peers are individuals who have lived experience and have been tirelessly advocating for inclusion in these spaces which are mostly dominated by providers. We need to elevate their voices and their advocacy. And some of these folks who are Asian that I know are people like Pata Suyamoto, Chakumatai, Rishma Valiappan. So just bringing their voices here as well. Also our research partners, which includes Asian Community and Referral Services in Seattle, Yunju Han in particular, thank you Yunju, and the Asian Mental Health Program when it existed in the Cambridge Health Alliance, whose director was Dr. Kim Niem. So thank you for your amazing mentorship through this process. My intellectual partners in crime, Urmi Chakraborty, Aliya Ismail, and Dr. Mihoko Maru, and our ancestors and elders for their sacrifice so that we can be here today and participate in these discussions. And then I do have to acknowledge the funders, so there they are. All right. So when I did this study, this is one of the quotes in the study that has always stood out to me. This was a young adult with lived experience who said, "Sometimes I have actually had trouble figuring out what's cultural versus what's an actual issue." Oh, I'm sorry about that. Okay, so the concept that I kind of want to start with here is the concept of stigma. So in many research studies on Asian Americans, shame and stigma is kind of cited as probably the most significant barrier to accessing treatment and hence the underutilization of mental health services. In fact, some go as far as to say that there is greater stigma of mental illness in Asian communities than other communities. Some cite the toxicity of silence and shame or the toxicity of the don't speak out cultural value. And we are all aware of mental health disparities that exist. So, you know, this has been kind of an understanding or kind of an explanation for this experience. So I am going to tell you that I'm not a fan of this term at all. In fact, in my experience of doing this work, it has been used excessively and very strategically to further disenfranchise and ethnic minority communities. That includes actually Black Americans and Indigenous populations, and of course, Asian Americans for navigating. So people have to navigate already hostile territory, which is a white supremacist system that you're kind of working within, that privileges a certain way of being. And it also, it was also sort of this reason why, and this is also part of the kind of conversation even within our community of professionals. And as a new immigrant to this country, I was in doctoral training and I needed to be in therapy or wanted to be in therapy for the experience and really learn how to do this. As a South Asian woman, I did not want a South Asian therapist because I worried that I would be further seen as lesser or as different, and that would be pathologizing. So I'll talk about my therapy experiences in a bit, but just to give you a flavor of that. But we need to make these conversations on underutilization and stigma in particular a little bit more nuanced and complex. And one of the best ways to do that is really to contextualize experiences. And that means really acknowledging and understanding history and context. So what does that mean? So let's contextualize this whole stigma concept, right? So colonization has shaped a large part of the history of much of Asia. Entire cultures were dominated politically, religiously, culturally, and of course then economically through violence, appropriation, dehumanization, and subjugation. So that has been the experience, the historical kind of traumatic kind of backdrop to a lot of what folks are coming in with. Even this kind of what we're hearing now with the recent shootings as hypersexualization is very much a part of Orientalist kind of discourse, right? And so contemporary evolutions of colonization has prevailed in much subtle form, you know, more subtle forms of oppression. And this is called neocolonialism. This is sort of this underlying rationale for colonization, which characterizes indigenous populations, and I don't mean Native Americans, I mean indigenous populations to that particular space, as uncivilized or backwards. And it sort of creates this binary that positions the colonizer as the savior and the kind of the superior person or the superior kind of culture in that context, right? And it also, what it did was sort of intentionally erase, edit, reconstruct this history of Eastern civilizations. And we see this in so many ways right now, and kind of this kind of extra, like yoga and mindfulness being kind of brought here, decontextualized, used as a very effective kind of mental health treatment with that, by stripping it of its roots and its context, and then repatriating it back to Asian countries, right? So it has that kind of now this root that, oh, you're not doing this right. And so then we've also had research in Asian American psychology, particularly by Dr. David, on the colonial mentality, which basically sort of it's manifested through any preference for something that's American or European, the rejection of one's cultural heritage and traditional values, disconnection from spiritual religious practices, and even internalization of self-deprecating views. It's an experience of sort of these emotional tensions that are constantly trying to traverse that result from fragmentation of identity. And then you break down these images of the collective and you're even alienated from your culture of origin. So here we have, in this image that you're seeing, you're looking at kind of European colonial hegemonic beliefs that influence psychological systems. You have domination, discrimination, and systemic oppression, and there's erasure and appropriation of Asian values and practices, all of which then contribute to this kind of experience of trauma and lack of well-being, which has traditionally not been a big part of the way that we approach mental health services for Asian American communities. So mental health disparities are essentially part of, related to this in so many ways. We have this disconnect from the culture of psychological services and even Asian cultural values, sort of this incompatibility between, services and what the values of the community, right? So in some ways, the values of that the therapy work brings focuses on autonomy and independence in the context of individualism, as we heard in Dr. Hong's presentation. As a person who was a recently immigrated Asian woman, South Asian woman, for me that was such a conflict because I wanted a genuine kind of connection, and interdependence and holism was very much part of my kind of story. There was also this focus on kind of insight, which didn't quite make sense to me. I'd rather talk about my headaches that I was having. So we experience things, a lot of South Asian people tend to experience their symptoms somatically. And that is very much a part of kind of the way we express our pain. But there aren't many therapists who work with the body or somatically. It's actually all about kind of focusing on your emotions and processing it, in fact, verbalizing it, in which I would usually respond, well, how important is it to label emotions? So we have this idea of name to tame them, which we're sort of trying to get our clients to actually identify. Whereas in Asian and good Asian mental health, in mindfulness, etc., there's such a focus on being able to sit with your internal experience, no matter what those emotions are. So to being able to actually think and experience them and really sit with them. And that relates to the next thing, which is around like one of the values of psychological services is around removal of suffering, which is again incompatible with Asian cultural values, which are around much more around tolerating suffering, right? So, this idea that, so when I would go into therapy, I'm like, I can handle it. I've been through worse. You can do it too. And complaining about it is a weakness. But as I've kind of progressed, I've been reminded that complaining about it in isolation is the problem. I can complain about it with a community, and that's what we're going for here, right? And that cultural adaptations of therapy work, that needs a lot of work. It's a lot of effort. And often, my version of it going into therapy was, can I just have a cup of tea with you, please? I think I'd feel more comfortable. So anyway, so the idea of recovery is possible and trauma and violence is real, but there was no acknowledgement of my colonial past or what my ancestors have been through or anything that I bring historically and what I'm dealing with in this particular context. So I'm going to show you an image that is probably going to seem very, very familiar to you. In kind of our understanding of psychological processes and the way we kind of think about this, we break up the mind and the body and the spirit, right? And so in a perfect kind of scenario, this whole kind of connection that we have, this space is probably where we want our clients to get to this integrated, beautiful space, right? Spirit, of course, we have a very hard time talking about because that's unscientific, right? It's not embedded in our understanding. So, we want to look at that in between space. But most cultural traditions that are not based on white European values tend to view, this tends to be their worldview, that the body, the mind are all contextualized within the larger spirit. Even, and by spirit, I don't mean that, you have to have a particular religious practice. You can believe in a holistic approach. So kind of having that holism integrated, and the body and the mind are seen as part of that process. So there in and of itself, there's this very distinct and different kind of worldview, right? All right, so coming to my kind of work and what I do, you probably in my introduction heard the terms recovery and rehabilitation. So I'm just gonna break this down real quick. I'm also aware of the time, so I'm trying to speed it up. So when we think of mental health, we think of this transactional relationship between the person and the environment, right? In treatment, what we do is we place a greater focus on the individual. So if the person has symptoms, and a cluster of symptoms that are called disorders, we then provide treatment to like medication therapy, etc., to then address the issue that the person has. Rehabilitation, on the other end, views the environment as far more important. What are the factors in the environment that are allowing someone to do the things they want to do or not, right? So it essentially addresses a person's functioning within their community. So the terms that we tend to use, particularly for people who have serious mental illness, is a psychiatric disability that includes an impairment, which means I am not able to do something. I'm impaired in my ability to do X. Dysfunction, I'm having problems in my functioning. You heard some of that in Dr. Hong's talk. And restrictions or difficulty in kind of fulfilling these instrumental roles, which are like work, school, family, right? So I'm having a hard time being able to be a good parent or be a good, I didn't mean for that to happen, sorry. So sometimes treatment and rehabilitation are almost like oil and vinegar. Are they different? Like how do we integrate them? But actually, if you think about it, they are pretty closely related, right? And there are these untapped resources out in the community. If you just focus on the individual, you're focusing on those inadequate skills, social isolation, self-esteem issues, health problems. If you focus on rehabilitation, then you're focusing on inadequate support, disempowerment. What is the person experiencing in relation to their environment? And so it actually needs to be a combination of both. So it is oil and vinegar, not oil and water, as the previous slide kind of suggested, right? So we can integrate these. In fact, rehabilitation and treatment in combination would improve skills and provide support, address misconceptions of mental illness. In fact, if you think about it, people who have physical disabilities, you use physical therapy to support them, right? To develop the strength in their legs to walk, let's say. But when physical therapy can't work anymore, then you provide a crutch or a wheelchair, something to help the person walk, right? And then you change the environment, like you develop wheelchair ramps, etc. But in psychology and in mental health, a psychiatric disability is often not characterized as a disability. We tend not to associate it that way. Those kind of supports tend to be much more soft supports, which means that people need more people support. And that's a really important piece when you're kind of working with Asian individuals. So real quick, I did this kind of family needs study. I'll skip over this so I can just share some results with you. So these are some of the things family members kind of shared. They talked about challenges with caregiving responsibilities that they had for individuals who were in recovery. There was a lack of community-based support. They didn't feel connected to the community. There was also a lot of silence and isolation around mental illness, which made their experience really challenging because they felt blamed and disconnected from their community. So this is what families identified as what would be helpful. Family being an integral part of treatment. So Asian families were really adamant that they'd be involved, that they need to develop coping strategies. They need knowledge and education around mental health and improved communication between the family and the person with lived experience. In terms of support, they really wanted Asian-centric counseling services, things that are culturally compatible and congruent, and good community-based resources, which for them were really, really hard to find. We also looked at providers and what they were saying. Providers were talking about how they felt stereotyped and experienced prejudice. They had very limited resources as Asian providers. They always had to kind of prove their legitimacy as providers of mental health services, as Asian providers. They talked a lot about difficulty managing boundaries in terms of self-disclosure, and they were not just doing therapy, they were also providing case management, they were working with the family, they were sort of like playing all these multiple roles in the lives of people, which was also very consistent with my experience as a therapist. The providers also talked about generally the challenges of having, working with somebody with mental illness. So that would seem familiar. They talked about communication challenges in terms of language. What did they say that they would find helpful? So they talked about Asian families as benefiting from a focus on wellness and functioning, that not to focus on symptoms, but actually on function, what a person can or cannot do. They also talked about the role of the provider in relationship building and providing education. This is just note, it's very consistent with what the families were saying. And providers said they needed support. They needed support and help and supervision around managing boundaries, customizing available treatment models so that they had strategies to use. They also wanted key assessments for immigration experiences, even family style of communication, etc. So this is, again, just relates to Dr. Hong's presentation so well. So I'm going to elevate a voice here for, this was one of the individuals who participated in the focus groups. This was a South Asian American daughter whose mother was in recovery. She said, for me to really heal, I needed to be away from my mother and I couldn't. I constantly stayed engaged with her, just pulled my, staying engaged with her, just pulled my healing down. On top of it, supporting her and having this cultural baggage, that communicating to the service providers that no matter how crazy it might seem, that I'm still capable of having a two-track mind, is what she said, where in one track I have anger at my mother and anger that she was an abuser. On the other track, I do want her to get treatment. I do want her to be happy. I do want to protect her. I do want to care for her. That is still possible. Just because I fight with her or just because in the process of healing, I confront her with some of the horrible things she did, and as a result, she feels bad, and that causes her to feel suicidal or whatever, that is not two different things, that I am capable of both. And this individual really kind of talked about the importance of kind of being flexible even around the confidentiality issue. So I'm going to try and wrap up here. I'm sorry I've gone over time, but just real quick. So again, I don't need to repeat this, but the importance of family and community. So mental health is an identity. So in psychology and therapy processes, we tend to think of our, this onion, right? You peel off all the layers, you get this beautiful inner core that you want to kind of tap into. In reality, social identities are like a garlic, right? You have all these different cloves that come together, and some are larger, which you're more aware of. Maybe you present, it's outward facing, it's more visible. Then you have those thin little slivers, which you really don't want to kind of deal with or bring to the fore, whatever. In this whole intersectional kind of bubble or garlic clove, mental health is one such identity because it carries with it all of the experiences and the historical traumas that people with mental health have experienced, right? The next one I kind of just want to highlight is raising critical consciousness. Sometimes as even professionals, we leverage our own knowledge and education in our systems that are very specific. It's very European, white American kind of focus. We use that to oppress our own communities. But we also need to raise awareness of racism in our communities. It shouldn't come as a surprise that racism is a factor in all of this. How to talk about it, how to deal with it, raising awareness of, let's say, Islamophobia. There are so many Muslim Americans who are Asian Americans who live in the United States. Awareness of casteism, for example. We really need to work on that kind of critical consciousness raising to create buffers for our communities so that when they do experience this trauma of racism, that it's not a shock, that they have the protective kind of gear to actually deal with this, because it's really, really bad. And related to that, working on racial identity. I don't have time for that now. Principles of recovery and rehabilitation, focusing on functioning is really important. And understanding the role of stress and trauma on the mind, body, and spirit as well. So really thinking of some wounds as being soul wounds that carry on from our ancestors that we're continuing to perpetuate, right? So I had a little model here. I'll just highlight this real quick. You want to elevate resistance, resilience, and recovery by addressing historical trauma through an inquiry of intersectionality. Elevate resistance to systemic oppression and resilience building in response to trauma. And incorporate, validate traditional beliefs and identities. So I'll just wrap up with another expression of gratitude to my fellow presenters, to Alice and Nisha for this wonderful setting, the Let's Talk organizers for doing this, and to all of you for being here. So, thank you.
Thank you, Dr. Millner.
We're super excited to get into Q&A with our panelists. I see that there are many questions already from the audience, and so we will mostly be going through in order, but we wanted to start off the panel discussion with one of the questions, which is very timely and relevant today after the past couple weeks of really horrible acts of anti-Asian hate crimes and violence. And so the first question for the panelists is, what are your thoughts on how non-AAPI clinicians can or should not bring up AAPI related crises? For example, the current crimes that we've seen in the past couple of weeks, if the patient does not initiate themselves. And as a follow-on to that, how might the current realities of these hate crimes that we're seeing impact the demand or need for mental health in our communities?
I can get us started if that's okay. Okay, so one of the strategies that I would use as a clinician when I would work with anyone who was different from me, which was pretty much anybody, is to sort of say to them, I don't want to assume that our differences are important, but if you ever need to talk about them, I would make space for them and I would encourage you to talk to me about it. As a non-AAPI person, I think you can pretty much make an assumption in some ways that people are affected one way or the other. The question is, do they want to talk to you about it? It's important to create space. It's important to acknowledge trauma and to also kind of engage in your own kind of awareness of the systems within which we operate. Because what seems like a crisis right now has been a crisis, let's say, for more than a year. It's a decades-long crisis in a system that is very, very flawed and non-functional, that doesn't create room for Asian American individuals and voices with all the stereotypes and prejudice that occurs. And what we're seeing now is just another flashpoint in history. It's like another little burst that we're seeing. So if we don't contextualize it within this larger framework of what we have seen for such a long time that many of us have been complaining about, then we're going to be stuck in this kind of point of, oh, this is the crisis and we need to attend to it and then let's forget about it after it's done. A lot of other ways in which people can feel like I need to take action now. It is really, really important to actually be thoughtful about the action you take in providing the support that you do. Because it's very, very, if it's not thoughtful, it's reactive, and reactive is dangerous. It can actually harm people more than help people. So I would start with acknowledging it with your client, creating space and room, and actually, if you haven't already, doing some trainings in AAPI mental health in order to be able to truly address this.
I just want to add on, I think what Dr. Millner is saying is right about creating space and allowing room for discussion, and kind of wanting to extend on what she said in the beginning about that even if the person is struggling, if they may not feel comfortable or want to talk about their feelings with you. And it may be related to being a non-AAPI provider. And even that can lead to a fruitful discussion and being able to be open to talking about the discomfort with sharing, and maybe even some concerns about feeling the need to have to educate or take on the burden of the therapist, I think is something that could come up as well. And I think all those things are important to name and allow for, not just trying to elicit maybe some of the pain and discomfort that the client may be experiencing.
I just want to answer the second part of that question. Will the demand for services or use of services increase? And I frankly doubt that it will. As Dr. Millner said, there's a context here. So there have been many crises in Asian American communities over the past 4 decades. And over that time, Asian Americans have continued to be the least likely group to use mental health services. So we need to think of creative ways to reach Asian Americans who are experiencing anxiety and stress and trauma around these recent events. It may be different support groups, it may be Asian American organizations, but in terms of mental health services, many Asian Americans do not see these as personally relevant. So mental health services hasn't been a go-to resource before the last year and the rise in anti-Asian discrimination. So I'm doubtful that it will become a go-to resource since the pandemic and after these murders in Atlanta. So we need to think of ways of making our resources more accessible. And this may not be through traditional mental health outlets.
And as a follow-up to this kind of line of questions, one of our attendees mentioned that the mental health field and society at large has a hard time placing AAPI discrimination, given its more invisible nature and contextual history, as many of you have mentioned. So what might you recommend kind of specifically or tactically to help our fellow non-AAPI mental health professionals understand these experiences better?
So Nancy, that's a really great question. And I just want to validate your experience around this. So I think it's really, really, it's an important acknowledgement that there are some, actually, let me back up. There was a colleague of mine who does social justice work, and she does not like the term allies, because allies somehow means that you're outside the system or this kind of group or community that they, in terms of what they're experiencing. But actually, allyship is about being kind of connected and understanding that what the community experiences is related to a systemic kind of flaw or a challenge. So, I hear you. It is shocking and surprising to see how many people are silent. And in our community, silence is sort of characteristic, right? There's so much silencing of our voices that happens. The way I would think about it at this point is, and I've been thinking about this quite a bit since last summer and the murder of George Floyd too, is accountability. Like, what are the channels of accountability that we as professionals have that would hold each other accountable to kind of really working on anti-racism as a whole? Because it's very tempting to be reactive and be supportive right now. Whereas actually what we really need to work on is change the dialogue around it. It is in the best interest of the privileged minority for, these conversations not to happen. And these are challenging conversations. So what are those accountability channels systemically that are going to actually hold people accountable to having these conversations and really working on what is truly cultural competence, because without the big picture, we're going to continue to have modern minority myths and perpetual outsider stereotypes. And I just want to shout out, make a point, I guess, not a shout out, but a point about even within our sub-ethnicities, like our ethnicities and sub-ethnicities, we have a lot of prejudice that exists. And even for us, we need to work on that.
Yeah, I'd say that non-AAPI therapists need to validate the AAPI person's experiences. So if they're talking about being afraid to go outside, this is not paranoia. This is based on actual risk, and these fears are very real. So physical safety and psychological safety, as I mentioned at the beginning of my presentation, are very important. So it's important for therapists to validate these concerns and not try to get the person to adjust to a society and a system that are racist. So I think therapists need to take these concerns seriously and not try to see these as cognitive distortions or something that resides within the client. The most helpful thing a therapist can do if an Asian American client is seeing a therapist is to do something practical. So it's this idea of gift giving that Stanley Soon and Nolan Zane developed, something practical, something immediately beneficial. And there may be other issues to address in therapy, but right now, physical and psychological safety are the most urgent.
I think another piece too, just to bring like another angle to it is, given the high number of people who identify as AAPI here, is when you have non-AAPI colleagues who are staying silent or being an AAPI therapist with non-AAPI clients as well, like how to navigate conversations about that too. I've had moments where some of my own patients have said to me, you know, I've seen what's been happening. It was very, you know, how to bring in that sort of conversation in the room as well when they're recognizing that I might personally be experiencing something. It's sort of a turnaround in that way. And again, I think allowing space for that and being able to name it and speak to it without it becoming about my feelings or emotions or feeling like the patient needs to take care of me. With my colleagues, I'm sure many of you have had this experience as well. It's been very troubling and disorienting to see that the people who are talking about all of this is mostly people who identify as AAPI. And I've particularly found that quite unsettling, particularly among my mental health colleagues. And until I'm sort of naming it or sharing it, has been when I've been getting sort of responses to it, and that's been hard. But I think, like what Dr. Millner was saying, I think it's still really, really important to continue to put a voice to it, put a name to it, and not be afraid to say something, even when everybody else is maybe being quiet about it.
Can I add?
Thank you.
Is it okay if I just add something real quick?
Yes, of course.
I think one of the things to just look out for are somatic symptoms. So people might complain more about having pain or headaches or things like that, that might be reflective of their internal pain they're experiencing. And also, if you have the power in your organization to do this, it is really nice to create affiliation spaces where people can gather without the white gaze, and to have people be able to talk about their experiences as being AAPI, being able to hash out issues within that group, and having some community resources to support that effort.
Thank you. So moving on to our next question, one thing that all three of you have brought up is being careful about not putting the pressure on your patients to educate the clinician about their culture. And so on that note, do you have any research that the attendees here can or should look at if they're interested in learning more or educating themselves on this line of work. And if there are any existing models or frameworks that incorporate various factors such as cultural and racial identity, collaborative curiosity, and colonial mentality, would you please share that with the attendees so that we can work on better educating ourselves?
Is there a way for us to be able to send papers and resources to those who have registered, Nisha? I mean, I think that's a great question. Is that possible?
Yes, if you send those along to Alice and me, we can definitely arrange for a way to send that out.
Great. We'll do that. I'll do that. And I'm sure Gordy has a lot of resources as well. And yeah.
Yeah, I can do that. What I discussed today is from 2021 American Psychologist article on the personal relevance of psychotherapy that integrates these universal and group and individual dimensions. So I can send that, and I'll think of others as well.
So I have this book on my table. I hold on to it. It's called A Race is a Nice Thing to Have by Dr. Janet Helms. It isn't specific to Asian Americans, but it is, it's a guide to being a white person or understanding the white persons in your life. So it's really, really nice in terms of understanding racial identity. And this work is very, very, I mean, Dr. Helms has been such an amazing, inspiring person. So if you really want to kind of delve into the racial identity literature, I strongly recommend looking up Dr. Janet Helms. And in terms of the person I cited for the kind of colonial mentality was Dr. E.J.R. David. I can send the work as well. And then I think there was one other. So it was racial identity, colonial mentality, and one other that I can't remember. But when I remember, I'm happy to share resources as well.
Great, thank you. Our next question is, how do you navigate the struggles and incompatibilities of individualistic and collectivist values when working with AAPI communities? For example, being told to stand up for yourself or tell your parents how you feel. What strategies would you use?
That's a great question. I think it's a big question. So the way that I typically approach it is being able to first identify what are the values and goals of the individual in terms of what they want. And oftentimes, similar to what Dr. Millner was saying in one of her presentations of that woman, what she was saying is that even though they're struggling, often my clients are struggling with their relationships with their parents who are Asian immigrants, feeling as if, you know, they're not acknowledging their independence, their needs and things like that. They still long to keep a relationship with them. And so there is this sort of tension between the two of feeling very angry towards the parents and towards their behavior and the values that they're upholding, and then at the same time wanting very much to maintain a relationship. And so I start there, and then we work a lot on trying to translate some of the behaviors that their parents may be doing and being able to understand, you know, if they don't say I love you, or if they don't show an interest in your emotions, but are continually asking if you've eaten, or coming over to do your laundry, or dropping off food for you, you know, being able to understand the function of that behavior and what they're trying to do and say, and sort of working with the client to accept that this may be their way of expressing their love, and how do we work to sort of accept that rather than trying to force a change of that on the parents, and thinking about it in those terms. So oftentimes that tends to go better, especially if the person is very much wanting to maintain their relationship while also knowing that their parents are unlikely to change how they are responding to the client. I'm also just very explicit about it. So, in creating that whole model of collaborative curiosity, I don't hold anything back. I talk about these are, more Western models of individualism. Here are more Asian models. Let's think about what your values are and how to sort of test out different strategies and see what seems to help with the situations at hand.
This is actually a related question that might go to you, Dr. Millner, given what you just previously talked about. AAPI community members tend to express their issues somatically, not verbally, which is how mental health clinicians were typically trained to react. So I guess how does that look when working with AAPI in therapy? Are there specific interventions that focus more on addressing somatic sensations more than perhaps verbal cues?
Yes, thank you for that question. So there's a lot of new kind of mind-body intervention work that's coming out. You can read about it in a great book called by Resmaa Menakem called My Grandmother's Hands, which is really great. It's about how trauma is held in the body, and those are extra trainings, I guess, that one can do. I personally, as a South Asian person, with my white therapist, who has lasted with me for several years. Probably one of the big reasons why I lasted with her is because she did a lot of somatic work with me over the course of time. That was concrete, and it was also something that helped me kind of understand I sort of relate to my body in a different way and understand that that's part of my being and cultural kind of experience. So there are a lot of trainings on that and very sophisticated tools and strategies that one can learn. I am personally not trained in it, but I did use a lot of behavioral strategies in working with communities, and people, really appreciated, the relaxations, the meditations you do, and yes, mindfulness, but hopefully from a much more holistic, contextualized lens. So if I can just go back to the family question too, for a moment, it's important to bear in mind that family is a really important source of support for people, even when they are conflicted relationships, right? Unless it's a clear situation of violence or abuse, which is when you really want to kind of think about the consequences of that. The fact that, especially like my immigrant families, there's a great risk to kind of it's almost to me a little bit unethical to create divides between families and their children in some ways. So it's a really kind of tough space to be in. And then to also understand in your work with second generation or future generations of children of migrants, of Asian immigrants, that they're code switching a lot. It's like, it's a bit like, and I'm going to use this analogy if it makes sense. It's like having 2 feet in 2 different boats on a very, very raucous river that you're kind of like trying to juggle and manage. So your internal experience is very difficult. And it's very easy when you're seeing the world outside, which is designed for a particular group of people to kind of believe that that's the right way to be, and what my family is doing is the wrong way. So to be able to have a dialogue and connecting that, and also really going back to raising critical consciousness with families as well as individuals, it's really important a lot of folks are left without, like a turtle without a shell in the sun, and that's not good for folks.
Could I just quickly say something about the somatic piece too? And I think coming from maybe just a different orientation, and one of the things that I also work a lot with people who are on the spectrum, and to me, it's an example where oftentimes they may not have the verbal capabilities to be able to identify what it is when they're feeling distressed, but it'll often be felt somatically. And what I found is there's a lot of parallel in that if you spend time tracking and being able to note, oh, you had really a lot of headaches this day, a lot of stomach aches on this day, or you were having whatever the problems are expressing somatically, and being able to tie it to specific situations, it helps to feel more clear on what's causing some of the difficulties that they're feeling in their body. I've seen this with my neurodiverse clients, but also with my AAPI clients, that you're creating, you're almost articulating that mind-body connection and being able to say, and so even if we never actually get to thoughts or beliefs or things like that, that cognitive behavior therapy would address, we're still making connections to different stressors and situations that come up.
Thank you. Our next question, this one might be a good one for you, Dr. Hall, but anyone, please feel free to answer. There's also a bit of questioning around studying AAPI mental health in academia. And so the direct question is, how do you address questions from others when they suggest that we are closing off ourselves to the clinical work that we do by only focusing on AAPI needs, and subsequently feeling dismissed in training programs as well when this is a topic of focus?
So thanks for that question. That is a challenge for all of us in this field to argue for, present evidence of the legitimacy of what we do. My meta-analysis showed that cultural adaptations, including for Asian Americans, are more effective. But this is a challenge in a number of ways. First of all, in terms of research funding for work on Asian Americans, in the last 25 years, the National Institutes of Health, which is the largest funder of research, devoted only 0.17% of its funding to Asian Americans. And this isn't just Asian American mental health. Most of the funding that they did devote was to cancer research, and then some money for work on aging. So the effect of the lack of funding is the lack of training opportunities as well. If you can't get funding as a professor in academia, it's difficult to be a professor and to train students, and consequently, there's very few programs and very few faculty members in psychology programs that focus on Asian Americans. So there are challenges in this area, and because of this invisibility again, many non-Asian faculty do not see the importance of this work, but it is important work. Asian Americans are the fastest growing ethnic group in the United States. I think, ironically, this attention during the past year to Asian American discrimination, including these recent murders, has brought light to these issues in academia. And I think this is an opportunity to show the importance of Asian American mental health and how these incidents, certainly the murders, but even microaggressions and other acts of discrimination, can affect Asian American mental health. So I think it is important to show that these are society-wide issues. I also think it's important to be bicultural, to have mainstream skills, and to use that as a platform to advocate for the importance of cultural adaptations and the importance of expanding the work to Asian Americans and other groups. Many of us who are senior scholars have had more than one area of expertise. And so it is important to learn the mainstream approaches, learn that language, and use that language to study Asian Americans. So it's an uphill battle, but it's an important one that we all need to fight. And it seems unfair that students or trainees or junior professionals should have to fight this battle. You have people working with you that are more senior, such as I, but it is an ongoing battle, and it's important that we advocate for Asian Americans, otherwise we'll remain invisible.
Just a quick add-on is just, I think, some strategies to appeal to the majority in some ways, to be able to see the importance of this is partly what Gordy is talking about in terms of the need and the growing population of AAPI, but also there's a lot of benefit from being able to look at different cultural beliefs and ways of healing and building better mental health, and being able to draw from that, study that, and learn more about that. How can that not be helpful just in general for individuals? And so, being able to study cultural practices and cultural beliefs and all of that can only help us inform not just ways in which people may suffer, but also ways in which people who may not be AAPI could also benefit to being able to improve their mental health. And so that's my hope, that it wouldn't just be because of need of the populations, but also we can learn from the cultures in which these individuals are coming from.
Thank you.
Maybe I just have one little thing to add. I agree with everything everyone said. As a researcher who wanted to focus on the AAPI community but didn't end up doing as much because of the reasons that Dr. Hall actually cited, I at this point I've learned to adapt. So now what I do is when I build a research study, either I collaborate with some of my other BIPOC colleagues so that I can include the South Asian voice in there. Or when I design a research study, I include subpopulations so that it seems like I'm studying something larger, but I have the subpopulation in there so that it gets, we get the attention and the information that is needed. The other thing is there are foundation grants who are more willing to support than the larger kind of typical, the federal funding bodies, which are harder to tap into. So it's just something to explore. And the final thing I would say is to collaborate with community-based organizations, and they're very good at getting grants. So if you collaborate with them in sort of partnering and doing a community university partnership in terms of research, that can be very effective as well.
Thank you. And we are so reassured by the amount of interest and questions that we've received from everyone. Keeping an eye on time, we have time for one last question before we do a final wrap, but I will definitely provide some information on avenues to connect and get your questions answered. So with that, the last question that we're going to tackle is a bit more forward-looking. So given all the kind of accessibility considerations, barriers, and of course, interventions and strategies that we discussed today, how do you believe that these relate to, or perhaps don't relate to, many of the emerging virtual platforms for mental health that have started to pop up? The example given is Talkspace. And this is something that Alice and I are actively working on with Anise Health. And so the question for you guys is, are there, do you see kind of hope for these ideas being integrated into accessible virtual platforms? And if so, how might you see that actually taking place?
Gordy, I'm looking at you, but you can't tell I'm looking at you because I figured you were talking about the app that you were creating. Did you want
Sure.
to talk about that?
Sure. I don't know that much about Talkspace or these other platforms. They are more accessible, but incompetence can be provided either in person or virtually. So, if they're not doing anything to make the approach personally relevant, accessibility isn't going to improve the situation. As I mentioned, we are trying to develop a problem-solving app for Asian Americans to deal with stress. So it's not only for patients, but something that's widely applicable. We're trying to get NIH funding to do this. There seems like some possibility that we will, but the idea here is to tailor an app to Asian Americans that they can use on their own without, without the stigma of seeking mental health services, and seeing something that is developed by and for them rather than something that was developed by someone who isn't an Asian American. And hopefully this would be an app that is seen as personally relevant to Asian Americans.
I will say too that maybe this is not an app, but being in the Bay Area, there's a lot of different platforms and ways in which mental health is getting more accessible than just the private practice model or in university or hospital settings where companies are providing access to services by paying, like companies like Lyra and other things like that, where they will offer mental health services as part of the benefits for the employees. And through these types of platforms, I've seen more AAPI individuals reach out because it does reduce barriers to care, and there's more visibility of different providers who are accepting clients, and there's more description of the types of work and specialties that these providers have, and I've seen that actually really has helped. This is anecdotal, not actual statistics, but increase access and interest in seeking mental health care.
Thank you. Thank you so much to all three of you for taking the time to answer those questions. Time has flown by, and we are unfortunately at the end of our Q&A session. We would like to kind of mention once again that we are so reassured by the high interest in this topic of AAPI mental health. We hope to continue the conversation with all of you going forward, and we'll share our contact information as well as the emails of our panelists at the end of the session. So stick around for just a couple more minutes.
And as promised, here's the slide with all of our contact information. If you have any questions about what Nisha and I are working on with Anise Health, please message us at info@anisehealth.co. We would really appreciate it if you can just take a minute to complete the feedback survey at the end of the webinar. Your feedback will be incredibly important and helpful for us to continue improving our events going forward. A link to the survey should appear on your screen when you close out the Zoom. And we'd like to end by thanking our wonderful panelists again for sharing their research and expertise with us. We'd also like to take a moment to acknowledge those who have worked tirelessly behind the scenes to make this event possible. Dr. Josephine Kim and Dr. Juliana Chen, thank you for providing us with this valuable platform to discuss AAPI mental health and for your continued mentorship. We are also really grateful for Jiaming Liu, Julia Kim, Juna Kim, Shub Agrawal, and the broader Let's Talk organizing team.
Thank you again for joining us, and we hope you found this panel meaningful. The recording of this webinar, as well as additional resources mentioned during the panel session, will be posted on the Let's Talk website after the event. So please check them out and feel free to share them with those who might be interested. with that, we're at the end of our conference. Our panelists, if you have any closing remarks in the last 4 minutes that you'd like to share, we're happy to turn the final kind of mic over to you, and that's it.
Thank you so much for the opportunity. Obviously, I think all three of us had a lot more we wanted to say, and so feel free to reach out if you had any questions or would like to talk more about specific things that I presented in my presentation. I'm happy to talk with you more.
Yes, thanks for having us and thanks for attending today, and stay physically and psychologically safe.
Also extending my thanks. So thank you so much for being here. And if there's anything I can do, please feel free to email me. It's really heartening to see all the questions. It's been really wonderful. And I want to thank my fellow panelists too, Dr. Hong and Dr. Hall. It's been incredible to hear you. Yeah, thank you.